My talk today is about approach to thyroid nodules in general. I'm going to concentrate more on thyroid malignancy. Concentrate in each slide just to fit this presentation on time. For the people who don't know me, I'm a consultant, head and neck oncology and microvascular reconstruction. I'm also an associate professor of otolaryngology, head and neck surgery. I'm interested, as most of you know, in thyroid surgeries and parathyroid surgeries. So I have nothing to disclose. Epidemiology, which is very important to know, thyroid cancer is ranked the 16th most common. It's the second most common cancer in females and the third most common cancer in both genders. So it's quite common in Saudi Arabia. So it's a quite important important malignancy to know about, especially in the Middle East and in Saudi Arabia specifically. Thyroid nodules. A patient comes with a thyroid mass, midline neck mass. You have to take a proper history and do a proper examination and investigation. Um, uh, because it's more common in some ethnicity more than others. We ask about the duration, location, size, presence or absence of pain, any other masses in the body, or progression or trauma. And then we ask about systemic questions about, especially about fever, weight loss, any inflammatory process, compressive symptoms like dysphagia or shortness of breath from this compressive mass. In some cases, if it's big, if the patient had any hypo or hyperthyroidism, and then we ask about the other systems. And then we continue our history with the past medicals, past surgical, family history, medication, allergy, or any history of social smoking or alcohol. So in summary, the most important questions that we need to concentrate about in history that is related to thyroid cancer is radiation exposure, family history of thyroid cancer, gender, being a male. Being a male is a risk factor for thyroid cancer, although it's more common in females. Ethnicity, like Filipino, it's more common in Filipino patients. Any history of previous radiation, any history of that indicates invasiveness, like hoarseness of voice or dysphagia or shortness of breath. So that's about the history. So this is the most important slide about history. Itself and the lymph nodes, if there's any large lymph nodes. I always scope all of my patients, especially those who are going for thyroid surgery, to make sure that the vocal cords are mobile. And we'll know later in the slides why the recurrent laryngeal nerve or the vocal cords mobility is very important to document it before surgery. So now again, in the examination, summary of the examination on specific points, risk of malignancy than just the benign nodules. The size of the nodules, if it's big, more than 4 centimeters, if it's firm, the presence of cervical lymphadenopathy, if there's a vocal cord paralysis, then that gives me a hint that this is a malignant process until proven otherwise. Investigation, I usually do a general blood work, especially thyroid function test and parathyroid and vitamin D. In some occasions, I don't regularly or stop depending on the case. Imaging, ultrasound is the most important imaging modality for thyroid enlargement, and it gives us more of the characteristics of the thyroid nodules. CT scan in some cases, MRI almost very rare, almost I never order MRI for thyroid masses. So this is a picture of the thyroid, and this is a CT that shows the right side thyroid mass. We order CT scans in some cases, usually if it's a large and suspecting retrosternal extension of the thyroid. If we're suspecting aggressive behavior like fixed thyroid mass, suspecting tracheal invasion like hemoptysis or shortness of breath, or there is a change in voice, or positive lymph nodes on examination or ultrasound. So on ultrasound, here are some of the important characteristics of the ultrasound that tells me this is more of an aggressive nodule than just a benign nodule. And here you can see in the top, in the bottom right of the slide, just a summary of the most important characteristics. So I'll go over it one by one. If it's solid, then tells me it's more of a suspicious nodule. If it's the ecogenic and wider, if there's an irregular margins, ultrasound demonstration of microcalcification is a risk, presence of lymph nodes. So I usually summarize it here in the bottom. The composition, if it's solid or cystic. If it's solid, then it's more of a suspicious nodule. Echogenicity, if it's hypoechoic, then it's more suspicious. If it's hyperechoic, then it's not. The shape, as I said, taller than wider. Microcalcification. Macrocalcification is not a suspicious feature. So most of our radiologists, I'm sure there are some radiologists on the audience. We use a lot. They actually use a lot the thyroid classification, and here is the top main headlines of the thyroid: the composition, echogenicity, the shape, margins, and echogenic foci, as you just mentioned it. And there's also scoring for each one of them. And this gives us a hint that this is either a suspicious nodule or not a suspicious nodule, and then we move forward to the next step. So just to summarize it, so we start with a proper history and examination, then we do investigation like lab work and ultrasound, and then after the ultrasound, we do the fine needle aspiration. And almost always, I do an ultrasound guided fine needle aspiration, not just an ultrasound, not just a fine needle aspiration in the clinic. So once we get the ultrasound results, we usually get one of these 6 categories. We call it the Bethesda classification. Bethesda classification is very important, and I'm going to tell you why it is important now. So we divide it into 6 results, either non-specific or unsatisfactory, either undetermined significance. Number 4, follicular neoplasm. Number 5, suspicious for malignancy. And number 6, malignant. So why Bethesda is important? Bethesda is important for 2 important reasons. Number 1, it is very important for communication, to discuss with the patient what is the plan and why are we doing this plan, and to discuss what is the risk of malignancy. Okay, so let's say the fine needle aspiration, the 3 here, then the risk of malignancy will be 5 to 15%. Let's say it came back follicular neoplasm or suspicious for follicular neoplasm, then the malignancy risk goes up to 30%. So it simply gives us an idea on how to discuss it with the patient and gives them numbers on what are the risks of this nodules. Then the second important use of this Bethesda is to determine what is the next step in the management. Usually for the thyroid nodules, either follow-up, hemithyroidectomy, or total thyroidectomy. And that depends on the Bethesda, on the cytology, on the FNA results. Thyroid mass in general, I would just summarize here that more than 80% of the thyroid masses are benign. So it is very important not to panic when a patient comes with the thyroid likely benign without doing anything. Just the patient comes through the door with a neck mass, then this is a benign until proven otherwise. If it's a malignant, the 80% of malignant thyroid tumors are of the papillary thyroid cancer type, followed by follicular 10%, medullary, hepatocellular, anaplastic, lymphoma, or metastasis. So the summary of the management, depending on the Bethesda results, if it's non-diagnostic, then it's better to repeat it. We repeat it in 4 to 6 months, not immediately. And follow-up is an option in these cases. Let's say the FNA came back benign, then a follow-up with serial ultrasound is a good option. If it's a flush of follicular lesion or a TP of undetermined significance or follicular neoplasm, the best option is to do a hemithyroidectomy. Although a follow-up option is there, but the best option is to do a hemithyroidectomy. If the FNA comes back as suspicious for malignancy or malignant, then I usually prefer to do total thyroidectomy plus or minus central neck dissection depending on the case. So this is just a summary to simplify the approach, but it's not actually a black and white, okay? But this is just to give you an idea on mostly what we do in these cases. So why do we do total thyroidectomy in cancer patients? Let's say a patient has a unilateral small thyroid nodule that came back malignant in the FNA. So why do we do total? Total is better because there's chance of potential multicentricity. The recurrence rate is still there. That's why it's better to do it, remove it all. So also the most important reason why do we do total thyroidectomy in cancer thyroid, it's better to follow up. Give the patient radioactive iodine. We cannot give the patient radioactive iodine treatment if the patient has a remaining normal thyroid. So it's always better to do total thyroidectomy if the final aspiration is malignant. What are the indications of thyroidectomy in general? If there's a suspicious of malignancy, if there are compressive symptoms, failed medical treatments of Graves' disease, and sometimes for cosmetic reasons. If it's large, huge, complications of thyroid surgery. This is very important slide. The recurrent laryngeal nerve injury. It's one of the nightmares of thyroid surgery. If it's happened unilaterally, then the patient wakes up with hoarseness of voice. If it happens bilaterally, the patient will wake up with an airway obstruction and stridor. I don't want to scare people about this because the risk of recurrent laryngeal nerve injury in a is way less than 1%. So 90%, this is not going to happen. Okay? So let's not panic about this. As you can see here in the picture, the recurrent laryngeal nerve here, it's very close to the thyroid. I always, in my surgeries, I find the nerve and I remove the thyroid off the nerve. And I usually use what we call the NEM nerve stimulator, nerve monitor, during surgery to make sure that the nerve is working before we end up the surgery. Hypocalcemia or hypoparathyroidism, it's common after thyroid surgery, but it's temporary. Only less than 2% of people would have a permanent hypocalcemia, and they need calcium for life, but this is extremely rare, and we should not panic about this as well, because it's a very rare complication. Neck hematoma. So central neck dissection. I usually perform central neck dissection whenever I have a positive lymph nodes in the central neck. Central neck is simply this box between the hyoid, the two carotids, arteries, and the sternum. I usually clean this area of all the lymph nodes whenever we have a positive lymph nodes intraoperatively or on radiology. So the recommendation of the ATA guidelines, the American Thyroid Association of dissection, whenever we have a positive lymph nodes, either radiologically or clinically, we do prophylactic central neck dissection only if it's a T3 or a T4 thyroid disease. What about lateral neck dissection? Lateral neck dissection, we usually perform it only if we have a positive Cytologically positive lateral neck node. We don't regularly do lateral neck dissections. What I mean by lateral neck level 2 down to level 6. So summary, whenever I have a patient in the clinic and I want to decide for surgery, first I have to decide, do I have to do hemi or total? And we know by now when to do hemi and when to do total. Simply total thyroidectomy if it's cancer, or multinodular goiter. Hemi if the pathology comes, FNA comes um, as atypia of undetermined significance or follicular neoplasm. Or if it's a T3 or T4, we do lateral neck dissection only with positive lymph nodes. We always have to keep an eye on the airway, and sometimes if the mass is huge and it's reaching retrosternally, then we sometimes need to do a sternotomy with the help of our colleagues in thoracic surgery. Here's just a picture of a huge thyroid mass that I did a couple of years ago. That was the biggest couple of pictures here. You see that huge thyroid pushing the airway to the contralateral side. This is when the baby came out. Here's the thyroid. Here you can see the big thyroid compared to the other side. What about the TNM classification? I'm not going to bother you with the details of the TNM classification of thyroid cancer or the papillary thyroid cancer. I just here want to hint on this. That I don't know, but anyways, so even patients, as you can hear, even patients who comes with distant metastasis of thyroid, and there are less than 55-year-old, then their stage is 2, still 2. Okay, and what I mean by stage 2, they have a very good prognosis. If their age is more than 55 and they have metastasis, then we follow the usual TNM that we use in other. Age has a very important role in the staging of thyroid cancer. Here's very important, another important slide. Just to tell you that thyroid cancer has a very, very good prognosis. So even with papillary thyroid cancer, a patient with papillary thyroid cancer, they should not panic. Their survival rate is like more than 98%. Okay. So quickly, I'll go over the types of thyroid. Of the thyroid cancers are papillary in nature. It's 80% of thyroid cancer. The survival rate is very high, more than actually 98%. There are sub classifications that are more aggressive. I usually have a mnemonic for this. Mnemonic, I call it itches, which is the insular type, tall cell, columnar, Hertel cell, hobnail or Hertel cell, and diffuse sclerosing. These 5 types of papillary thyroid cancer. So usually papillary thyroid cancer comes with these histological features: papillary architecture, stemoma bodies, nuclear grooving, inclusion bodies, and orphan Annie nuclei. Orphan Annie comes from this old cartoon. You can see her eyes are white, and that's how is the slide. You can see white nuclei here. I talked about the treatment. I'm not going to go over it again. So what about radioactive iodine therapy? Radioactive iodine therapy also, it is actually indicated in intermediate and high-risk patients. So intermediate and high-risk patients is here. I don't want to go into this crowded slide, so I'll go back and to my summary. I usually summarize it in here. So tumor more than 4 centimeter, presence of extra. I talked to you about it, insular, tall cell, columnar, hobnail. These are the unfavorable histopathology. The presence of angioinvasion, positive lymph nodes, more than 5 lymph nodes in the central compartment or more than 3 centimeter in size, or lateral lymph nodes, or the presence of metastasis. So these are the only indications, intermediate and high risk patients. These are the patients who need radioactive iodine. Not all the patients with thyroid cancer will require radioactive iodine. طيب. How do we follow up thyroid cancer patients? Usually by regular physical examination. We do thyroid hormones and TSH levels regularly, and usually they are monitored and followed up by our colleagues in endocrinology. Thyroglobulin levels should be closely monitored. Stimulated thyroglobulin, ultrasound. In rare occasions, we do diagnostic radioiodine scanning, but the most important ones, the ones in the box here, thyroglobulin, usually follow up the trend of the thyroglobulin level, which is the tumor marker of thyroid cancer. We usually monitor these in the first 2 years, and then every 5 years for 20 years. So increased serum thyroglobulins are highly sensitive, 97%, and specific for thyroid cancer. We'll have cancer with surgery if the recurrence is more than 1 centimeter, and if it's less than 1 centimeter, then radioactive iodine would take care of it. This might be too advanced for today's talk. I'm not going to talk about it. Yeah, here. So molecular testing. There are new advances in thyroid nuclear scanning. There are well-known two types of studies of nuclear testing or genetic testing, sorry, that we order it in the gray zone nodules, simply patient with ATP of undetermined significance or follicular neoplasms. We can order this genetic testing. The first one is the ThyroSeq. The ThyroSeq, when we order it, it's a very good tool to rule in disease. Let's say a patient comes with an equivocal nodule that we're not sure if it's malignant or benign. Then we can offer them this genetic testing. If cancer, then it's 90% cancer. Then we have to do surgery about it. And that's what I mean by good to rule in disease. What about the Affirma test? The Affirma test, simply we do it to rule out cancer. So to explain it more, let's say we did the Affirma test. So Affirma test, we do it on the FNA. We do an FNA and we send it to the Affirma company to do the testing. And if it comes back negative, then it's for cancer, then it's 90%. As cancer, then we cannot depend on it. Might be wrong. So these are new advancement in thyroid genetic testing, and many people use it, although it is expensive because we have to send the slides to the States because there's only two labs that does these testing. Follicular carcinoma, the second most common thyroid cancer in 10 to 15% of patients. It's usually the survival rate is less than the papillary thyroid cancer, and thanks God it's less common than papillary. It's 60% 5-year survival. Usually, to differentiate between follicular adenoma and follicular carcinoma, we must have a capsular or vascular invasion to make the diagnosis. So we cannot make it with an FNA. We have to do surgery to make sure it's not a follicular carcinoma. Hurthle cell carcinoma is another variant of follicular of the worst cancer of the human beings. It's very aggressive. Thanks God, it's very rare. It's less than 5% of all thyroid cancers. Unfortunately, the survival is very poor. It's usually 3 to 6 months. And usually they present with, usually present with a large thyroid mass that is rapidly growing, and within few weeks, a few months, and usually it happens in the in older age group, in the 70th decades of age. Sorry. 1 second, sorry, I just got some technical issue here. 1 second. I just have few slides. I'm not going to be long. 5 to 7% of all thyroid cancers. It happens equally in male and female, and it usually presents from the beginning with cervical lymph node metastasis, and the distant metastasis rate is only 8%. And it originates from the parafollicular C cells. So it doesn't originate from the actual thyroid cells. It originates from the C cells that is attached to the thyroid gland itself. Sporadic and the familial. The sporadic has the worst prognosis and it's more common, 80%. The familial type is only 10 to 14% of the medullary thyroid cancers. Medullary thyroid cancer is part of the MEN syndrome. So surgery is the only treatment and no rule of radioactive iodine in medullary because, as I just mentioned, it originates from C cells and not from the thyroid medullary thyroid cancer. And because of 30% of people would come with lymph node metastasis, so we usually do central and lateral neck dissection upfront for all medullary thyroid cancers. So the treatment of medullary thyroid cancer is a little bit different. It's only surgical, and it's a bit more aggressive surgery than the papillary. Again, whenever we say thyroid cancer, we mean papillary thyroid cancer. When medullary thyroid cancer is rare, not as common. The follow-up of the medullary thyroid cancer, usually we do it with serial calcitonin and serial CEA, and these are the tumor markers for the medullary. On the other hand, the thyroglobulin is the tumor marker for thyroid cancer or papillary thyroid cancer. Measuring calcitonin determines the success of treatment. It indicates recurrence if it happens. It serves as a good as familial types or hereditary. Ret oncogene is the gene responsible for the familial medullary thyroid cancer. If positive, 90% will get medullary thyroid cancer in the first 2 decades of life. So sometimes in families with familial medullary thyroid cancer, we do prophylactic thyroidectomies. My last slide of the day is approaching thyroid nodules in pregnancy. Gynae people. So how do we approach thyroid nodules in pregnancy? Thyroid scan should not be performed, of course, during pregnancy. Fine needle aspiration is recommended for suspicious nodules and lymph nodes. Early positive fine needle aspiration for malignant lymph nodes requires surgery in the second trimester. So if we have a positive FNA for the lymph node, then خلاص لازم نسوي, we have to do surgery in the second trimester. So 1, 2, 3, or 4, or 5, then we don't need to do surgery during pregnancy. If the FNA comes back as Bethesda 6, what I mean by Bethesda 6 is malignant thyroid cancer, papillary thyroid cancer, then we see if the patient if she's in her first half of pregnancy, then we do just ultrasound monitoring. If it's stable, we do the surgery after delivery. If it grows, then we do it in second half of pregnancy, then we just do the surgery after delivery. So simply, just to simplify it, if we have to do surgery, then we do it in the second trimester. Otherwise, we try to monitor the patient until she delivers bisalama, and then we do the surgery. As we know, thyroid cancer is a very slow-growing tumor, so we don't have to rush to do anything. So we only have to rush and do surgery if it is growing fast or if there is positive lymph nodes and we have to do something. Everything you need to know about thyroid cancer and thyroid tumor approach to thyroid nodules, you can find it in the American Thyroid Association guidelines. That's what most of the thyroid surgeons and thyroid endocrinologists use as a guideline.